Top Med Talk.
Well, hello, I'm Desiree Chappell, and this is Top Med Talk. We are coming to you from the American Association of Nurse Anesthetists 2019 Annual Congress in Chicago, Illinois. The AANA 2019 is a gathering of over 3,000 certified registered nurse anesthetists, or CRNAs, for the largest networking and educational event in nurse anesthesia. Now, over the course of the next 3 days, Top Med Talk is going to be sitting down with presenters, AANA leadership, and delegates to discuss hot topics in the CRNA community and anesthesia practice in general. And as always, I'm joined by Editor-in-Chief of Top Med Talk, Monty Mythen. Hello, Monty.
Hey, Desiree. Great to be here.
Our topic for discussion this morning is caring for the transgender patient. And we had the privilege to sit down with a member of the AANA's Diversity and Inclusion Committee, Jose Castillo. Now, Jose authored a two-part series recently in the AANA News Bulletin, Caring for the Transgender Patient. Jose, thank you so much for joining us this morning.
Good morning, Desiree. Thank you for having me and getting this word out for everyone so that we can talk about a topic that's always been pushed under the rug.
Yeah, absolutely, it has. When we saw the topic, I kind of at first wasn't for sure what we were going to be discussing, and then I read your articles and saw that it was really how we as anesthesia providers can be more sensitive to the topic of taking care of the transgender patient within the scope of perioperative care. So, Jose, just give us a little bit about your background, where you're from, what you're doing right now in your own personal practice.
Yeah, I am a full-time assistant professor at Texas Wesleyan University, but I still live in Naples, Florida, and I practice clinically there also. I have been involved with the AANA for the past, since 2005 when I started. I got enthralled with everything that they're doing, and I absolutely love anesthesia. But the reason I came into the topic of the transgender is because our little town of Naples, Florida is a little bit sheltered from the world. Mm-hmm. I don't know, but in the past 12 years of my practice, I only came across 3 transgender individuals, and it was a challenge, and it was kind of disheartening to see people talk and whisper, and I thought that we can do better. Yeah. As anesthesia providers, we should not look at people regarding of their choices and their beliefs and their actions about themselves, but we need to treat the individual that is in front of us. And that's what sparked this interest. And then when I got more involved with the AANA Diversity and Inclusion Committee, that's when I'm like, we need to do more. We need to present this topic. We need to expand our horizon. We need to educate our providers so that all of us will be on the same page with best practices for the care of transgender patients.
Yeah, it definitely is. In practice now, we're seeing that transgender patients a lot more, not necessarily just for having surgery themselves in their transformation, but also just taking care of patients on a routine basis. And and you can see those patients all over the country. So, Monty, you've had a little bit of experience.
Well, where I work in the United Kingdom at University College London is one of the major andrology centres in the United Kingdom. So colleagues I work with have been doing gender reassignment surgery and all of the support services that go with that for decades now. So we are very familiar with caring for transgender people, both through the transition from one sex to another, but also after that. And as a result of that, also, we attract quite a lot of transgender members of staff because we've been there for a long time. They're very comfortable working with us. But when we were preparing for this last night, I discussed the fact that gender reassignment is a mainstream treatment that's available on the National Health Service. So our National Health Service has made a decision a good time ago now to say that as this is a condition, when you badge it as a disease, that makes it sound as though it's a problem in some way, but it's not. It's a condition. It's not a lifestyle choice, and therefore to provide appropriate services to allow people to make transition from their physical appearance to their emotional and hormonal state is mainstream treatment.
Yeah. So, Jose, can you start us off and just give us a little bit of background about maybe how, the percentage of patients that we're taking care of now? Do you have that information?
Yeah, I have a little bit of demographic information, but this is available from 2018. This is from Newport. Like in 2012, there are 3.5% of American adults who self-identified as transgender. And then in 2016, there were 4.1%, and in 2017, it's 4.5%. The World Professional Association for Transgender Health also published their standards of care in 2017, and they have identified 1.4 million Americans who are transgender. So they are there are individuals, members of the LGBTQIA community that is around us and that would need care not only for sex reassignment surgery and what I have encountered for endoscopies, EGDs, colonoscopies, appendectomies. They need to see their primary care providers and other clinicians. They need to go to their physical therapists, their occupational therapists. And the challenge lies not only with us, with anesthesia providers, it's all encompassing because of there's going to be mistrust, and some people get refused care and get marginalized and discriminated, so they don't go back. So that's a big issue outside of anesthesia. So I think that there are published articles out there about case scenarios and essays talking about like it needs to start from the security guard, the policy should trickle down to the secretary, having to use the appropriate pronouns and asking what kind of names that they prefer to be called all throughout their care. And to incorporate, again, another challenge also is with the software, with our electronic medical records, because right now I have heard of some published data that there are software out there that there are drop-down menus on either if they're in transition, where are they at, are they in a hormonal phase, are they on the sex reassignment surgery phase, or are they only just starting and they are just on the cross-dressing or the dressing part of what society conforms with the gender that they are identifying with.
Now, Monty, I know, and we'll ask you in just one second, through the NHS, there are policies, there are some guidelines that are available through your National Healthcare Service. Before we do that, Jose, is there anything like that within the U.S.? I mean, is there any published guidelines from Medicare or Medicaid or any other societies?
With the AANA, we are working on a white paper because the policies and procedures that are available are very sporadic. And even in my community hospital, there's no policy and procedure. I ask about with our nursing organization down there, and there is no set policy. So I think what my next step after the publication of the best practices would be to get those policies in place and get a template out there like a white paper and give it to the community for use.
Yeah.
But to answer your question, there's none. That's why we're trying to get everyone educated and be on the same page with best practices.
I'm surprised there's no like ARN or any other nursing communities that have anything out there.
No, there was a published article by Tolinch and colleagues in 2018 for perioperative care of transgender patient. And I believe this is with the Analgesia journal. Yes. And I believe there are some out there.
Yeah.
You have to dig for it.
Yeah.
Really, it's not on the mainstream media like we think it should be.
Yeah.
But I will continue to research.
Yeah. Monty, so tell us what you have found or what are in the guidelines for the NHS.
Well, I think we'll put the link in, but the National Health Service has what I think is a very useful set of summary pages on the website, which includes the legal status, so the Gender Act of 2004 is in there, which is when there are certain legal changes with regards to you can, for example, apply for a certificate of making transition. So there's a legal construct around it. But also in there is just simple things like which terms we use. So the summary term they chose was gender dysphoria, recognizing the fact that it's both physical but predominantly mental from the point of view of how you feel is an important component of which track you choose next. And at the front end, it just, that simple definition, it says gender dysphoria is a condition. So it's important it says it recognises a condition where a person experiences discomfort or distress because there's a mismatch between their biological sex and gender identity. It's sometimes known as gender incongruence. And then it goes on to say that it's the choice of the patient. So there's a need to demonstrate the fact that there are psychological issues, but also hormonal issues, and then there are different support systems and options, and that hormonal transition plus or minus the final surgical transition from male to female or female to male. But we're sort of pretty much stopped chattering about it now. We're not. It's not one of those sort of uncomfortable things to talk about.
Maybe
I don't know where you are on the journey
maybe
here.
your facility. But from my own personal experience in Kentucky, it's much like yours in Naples. I mean, I've taken care of patients along the way, not in any kind of transitional surgery, but again for colonoscopies and routine kind of care. And it's still for me. I mean, being in kind of Kentucky, I mean, I feel like there's still a lot of unknown. People just don't understand it. and disrespect, I think, for it. So I wish we were a little bit further down the line, but maybe this is one of the conversations that's going to help us get there, right, Jose?
I hope so. Yeah, there's a lot of mistrust with the care of the transgender individuals because of the marginalization and the whispering that happens behind their care. And I do think that this conversation will catapult into more of an awareness with everyone, so that we can all be addressing them as individuals and not as people who made the wrong choice. Yeah. Or against a religious belief that we do believe in, and that we can just address them as individuals who need care.
Yeah, right. Just like we would in anyone else. I mean, I feel like, as far you mentioned the LGTB, can you talk? Say that out, because there are a lot of different letters. So I want to make sure that we understand what those are.
So the LGBTQIA is the I don't know if they're... Yes, they are an organization, and it's with the lesbian, gay, bisexual, transgender, queer, intersex, and asexual. Okay. With the acronym. And the push for that is for acceptance with the community, for awareness. I am a member of the LGBTQIA community, and I have a husband. And we have 2 kids. And I do think that sometimes we get the looks when we go to airports, and I'm daddy and he's papa. So I feel the marginalization, and just imagine that magnifying on a level with a transgender patient that looks halfway through the transition, or probably not even halfway with anything but close to just dressing the part of the gender identity that they are matching with their own self. So it's very sad, and the marginalization actually goes back down to like how willing are we to provide for care as clinical practitioners. Yeah. There is a study out there that I would like to mention. It was published in 2018. This was part of the articles that were embargoed, actually, and I was invited to. Oh, I know. It was interesting. It was my first time, and I'm like, I have to Google what embargo means. I mean, I knew what it meant, but I'm like,
why is the study?
I'm like, because it was a very sensitive topic. Okay. So, but it was released in December of 2018, and it was done by Shires and colleagues. It is a study in a Midwest health system where 53% of the practitioners were surveyed and asked if they are willing to care for transgender patients. And 53% of them already do. But the biggest barriers that were tackled with this study is of lack of familiarity with transition care guidelines, lack of training in transition-specific care, these are all quoted, lack of exposure to transgender patients, and lack of knowledge about transgender with all personnel. So it's everything from like what I said earlier, like the security guard, going to the receptionist, going to the unit aide, and then the physical therapist throughout the continuum of care.
So that in that is a suggestion, the fact that in the USA, legally, you're allowed to discriminate. Because in the UK now, it is illegal to discriminate. So you can't, as a carer, you can't express a choice to look after somebody or not. That's discrimination. And if you do pursue that, you'll be subject to the full force of the law, because it's a crime to discriminate.
I don't know about the full force of the law, but I have seen people refuse based on their religious preference or what their beliefs are. And Are
you allowed to not look after Catholics? Or
No.
I do.
I say that as a Catholic.
I was there. Me too. Catholic too. I know. No, but I think I have worked with physicians and anesthesia providers that won't care for any surgery that is considered an abortion in that specific instance, even if it's something that is,
sterilization.
Sterilization procedures.
Attempted suicide, even for our prisoners who are already on the row.
Cubs fans.
I think you are allowed to. I don't think you.
You can refuse as long as there's alternative care. Provided. If there's no alternative care, then they have to seek care somewhere else. Yeah. And of course, you have to state your reason publicly. It's not because of I don't really like this individual, because that would certainly be discrimination. Yeah. So that's why with the education process that what we're doing, I think the best thing to ask ourselves is not, are we going to be educated? But the real question is, are we ready to be educated? Mm-hmm. Because if we are not ready, there's no learning that's going to occur, and the proficiency and the competency level of all the providers across the board is not going to happen. They're just going to do whatever they want to do, and it's not going to trickle down. So the entire system that we all the time need a team to perform is going to be a little bit dysfunctional, and then the outcomes would be poorer, as opposed to if the entire team are on the same page, on board, and are educated, proficient, and competent, and are willing to be educated.
So, in your articles, there are issues with regards to general education. In other words, we all need to be better informed about all of this. There are issues with regards to becoming more comfortable with saying to somebody, what would you like to be called? Do you now want to say he or she? Mm-hmm. But then there are specific issues related to where they are in the treatment pathway. So are there any specific, hormonal therapy issues that everyone should be more aware of?
Well, perioperatively, there are published studies that say that there are no adverse events or outcomes that come with hormonal replacement therapy. But there are anecdotal evidence out there that other centers are using, like in Boston. They stopped androgen treatment for female-to-male therapy 2 weeks prior because they wake up like teenagers. So they got that same delirium, they got that they want to punch you.
Because of the testosterone.
Yes. It's a little too much, so they want to wean it out or down so that when they wake up, it's good. The other aspect of care that is related to hormone would be the use of Sugamadex. If they still have the reproductive parts, they need to be advised, as sensitive the conversation is from female to male, that if they still have the reproductive parts, they need to cease from reproductive actions because they might get pregnant.
Yeah, if they're taken. What about any issues with estrogen or some of the female hormones with clotting and DVTs and things like that?
It is. It is published, yes. Mm-hmm. They need to go with a usual protocol of prophylactic medicine with sub-Q heparin or Lovenox. Sorry, I'm using trademarks, trade names. And or sequential stockings, the same protocol that we use for everyone who are at high risk for venous thromboembolism intra-op.
Okay. And then as far as some of the recommendations from your paper that you have for us as care providers and how we do take care of these patients and be sensitive to their needs, what are some top three of recommendations that you have for providers?
I think we already do the number one with everyone. Like when I go to my patient, I introduce myself and then I ask them, what's your name? Of course, the two identifiers that we are required to do for proper identification of our patients, and then the birth date. And then I go back to their name. So I see that you have two names. Which one would you prefer? Mm-hmm. Because some of our colleagues, like I went with Delphin when I first came here in the United States in 2000. That's my second name. Mm-hmm. And I don't know why I did that, but then that was like a preferred name. Like everybody who I knew then, they call me Delphin. But all my life, I'm Jose. We need to just ask like their second name. Some people even do with their abbreviation. So we already do that. So it's number one when we care for any individual across the board. So at least that's going to be easier to do because the transition is not going to be like, oh, I need to do this special thing for someone because that's what they want. Am I going to cater for them just because? Now, what am I going to do with the other sectors of our population? I'm going to cater for everyone, and that's going to be a topic for a different discussion, but I guess the answer is yes.
Yeah. Yeah, that's true.
And aside from that, the number two question would be, the number two thing that we really need to dive into is ourselves. What are our beliefs? I've been to CRNA and SRNA Facebook page, and there was a talk about pregnancy testing. And what should they do? Do they still have the parts? Is number one question. If they do, then they need to be tested. It is, we are liable.
Yeah. But we need to figure out how to have that conversation with our patient in a sensitive way.
Yes, definitely. Respectful, sensitive. I always tell my patients, I'm sorry. I have seen patients that I have said like, oh, we can't do your procedure. I know you're 52 years old, but honey, you're pregnant.
I
mean, it doesn't.
Shock.
I know it came as a shock. And she's like, there's no way. And I'm like, well, it is. It shows it. We can do the blood test to test it more.
Yeah.
But then, so that is one of the things that we need to be sensitive about, is to really dig deep and how do we want to be treated as individual, which translates to the golden rule.
Yeah.
Right? How do you want to be? what we want to be treated by others.
Yeah. One other aspect that I saw in the article that I thought was interesting, and had to deal with this myself, but it could be like legally part of they have to sign, or you have to make sure that you ask the patient about this before surgery, is if they have any type of equipment or binding or, prosthesis and things like that. And what are the guidelines for that right now? Because if you don't ask to remove that and make that part of the documentation, then you could be held liable for that.
Oh, definitely. Yes. Assault battery can come into play depending on how much you offend the individual. Mm-hmm. But yeah, external body contour shaping, gender expression, equipment, or paraphernalia, it's long.
Yeah.
Come in different shapes and forms. There's breast binding or padding, depending on what transition phase they're at, from male to female or female to male. There could be genital tucking. There's penile prosthesis also. Padding hips and buttocks can also be a few of the gender expression paraphernalia or equipment that they use. And it could be a challenge for us providers because there could be open wounds or sores that are there that they could be hiding also. So I do think that we need to ask the question, as is, to tell them that we are doing this to provide you with the safest care. Because if I don't know, I would not be able to do the safest care for you as much as I can as your anesthesia provider.
Yeah. So I just think that's a really important part. Well, Jose, thank you so much for sitting down with us. We really appreciate it. It was a great conversation. I think this is really going to help open up more conversations to come about sensitive topics in general that we need to be talking about as healthcare providers, not just anesthesia providers. So we really appreciate you taking the time and sitting down with us.
Sounds like we should do a mini-series on it.
We should do a mini-series on it. There are a lot of different topics that we can talk about, especially in the diversity and inclusion aspect of healthcare in general. So hopefully we can have you again on the show.
I would love to. Thank you, Desiree.
Yeah, great to meet you. Thank you for your work.
Thank you for this opportunity.
We really appreciate it. Good luck with everything that you're doing. And if we can help you in any way, let us know.
Thank you.
All right. Cheers. Thanks for listening.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.